Hello, welcome everyone to the PrecisCa Lung Cancer Tumor Board. I want to welcome all our panelists today. I am Ramaswamy Govindan, a medical oncologist at Washington University in St. Louis. I'm joined today by our experts. We'll start out with the introductions. Dr. Ginsberg.
Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Imaging and Vice Chair for Education at Memorial Sloan Kettering Cancer Center and Professor of Radiology at Weill Cornell Medical College.
I'm Larry Keston. I'm a radiation oncologist in the Detroit, Michigan area for Michigan Healthcare Professionals and Genesis Care USA Medical Director in Michigan.
I'm Tom Stinchcomb. I'm a medical oncologist who specializes in thoracic oncology at Duke University in Durham, North Carolina.
Hello, I'm Dr. Seth Force. I'm the Kamal A. Mansour Professor of Surgery and Chief of General Thoracic Surgery at Emory University Hospital in Atlanta, Georgia.
This is a 56-year-old man with the suspected stage 3 thymic carcinoma who presented with dyspnea, exertion and decreased exercise tolerance and had a good performance status with a past medical history remarkable only for hyperlipidemia and obstructive sleep apnea, no history of tobacco or alcohol abuse, and no family history of cancer. The CT scan, we will look at this in a minute. Reveal anteromediastinal mass, and the PET scan we will see in a second. The biopsy was consistent with squamous cell carcinoma, TTF1, CK7, CK20, CD1117 positive, and deemed surgically unresectable. And Dr. Ginsberg, do you want to comment on this?
Yes, so we don't have the images from the CT scan, but that did demonstrate an anterior mediastinal mass, which apparently invaded into the superior vena cava. And additionally, there was pulmonary emboli. On these images from the PET CT, we see that the anterior mediastinal mass is FDG avid. And in addition to that, we have a large right paratracheal lymph node, which is also avid. And no extrathoracic metastases were seen.
Thank you, Dr. Ginsberg. So the biopsy was deemed consistent with thymic squamous cell, not lung squamous cell cancer. And how would we manage this patient? Dr. Force, what is your approach to the management of patients like this with thymic carcinoma?
Sure. So we know that these are more aggressive tumors than the malignant thymomas. However, the squamous cell cancer patients tend to do a lot better than the adenocarcinoma variant or other even less common variants. So, if we're going to consider surgery for a patient like this, we would give that patient neoadjuvant systemic therapy and look for a response. Even with cable involvement, that can be resected and reconstructed at the time of surgery. So it's not uncommon that the vena cava or nominate vein are involved with these tumors. So it's not uncommon that we have to resect or reconstruct those veins. So that doesn't necessarily rule out resection. It doesn't look like it's a giant or huge mass really encompassing other vessels like the aorta. So I think starting with neoadjuvant chemotherapy or chemotherapy and radiation, if that's what's decided, and then seeing if we can move on to surgery after that based on the response.
So assuming this patient had a good performance status, no surgical contraindication, you would be open to surgically resecting a tumor like this, even though there is involvement of the node?
Yeah, I think so, as long as we can get a response. I wouldn't use surgery as the first treatment option. I think they would need some neoadjuvant therapy to show response and lack of progression during that. If they progress through systemic thyroid, then I wouldn't offer them surgery because it's going to be, a bigger operation. But the reality is that, it's not like, say, lung surgery, for example, the thymus gland performs no function. So just removing the thymus gland, and I would argue that maybe reconstructing the vena cava may actually have a positive palliative benefit for this patient, who may be prone to getting superior vena cava syndrome, which is a whole other problem down the road.
Not to dissuade you against surgery, but would the presence of pulmonary embolism make you rethink about surgery?
I mean, only if for some reason we thought the pulmonary emboli were tumor emboli. If we thought the tumor had invaded through the vena cava and then, embolized into the right ventricle and then out to the lungs, I wouldn't do it if we thought those were tumor emboli. But if we thought that those were just regular pulmonary, hematogenous emboli and not related to the tumor, that would not necessarily dissuade me from doing surgery. Obviously, we would have to figure out where they came from and take steps to try to, minimize that. I think it's another, reason to start with systemic therapy, because we could anticoagulate the patient and get, several months of anticoagulation before considering surgery.
I'll preface the discussion further on with my own concern here when we discuss the neoadjuvant versus definitive chemoradiation. We don't want somebody to get suboptimal therapy and then deemed to be unresectable or not found to be surgically, eligible. So we want to give them the best option. And so I always want to make sure that if you decide to go on the neoadjuvant approach, I almost plan as if surgery may not be done, and then plan the optimal treatment. So putting that in the context, now I will turn it to Dr. Keston and Dr. Stinchcomb. Dr. Keston, you first. How would you approach that with that dilemma? I'm sure you face that too in these discussions.
Yeah, so typically from a radiation oncologist's perspective, thymic carcinomas are handled very similar to non-small cell lung cancer for us. So this particular case, we would typically give concurrent chemotherapy and radiation treatment, possibly followed by surgery. As Dr. Force has mentioned, sometimes these particular tumors can respond very well to chemotherapy. So I suppose it's slightly more likely for someone to give some neoadjuvant chemotherapy alone in our practice, followed by chemoradiation if it's not responded well enough. But typically a case such as this, for us, we would begin with concurrent chemotherapy with standard fractionation radiation treatment. We would typically take it to a full dose of 60 gray in 30 fractions, and then surgery would be considered after that.
Terrific. Dr. Stinchcomb.
So these are always difficult cases, require often like a path review to make sure the diagnosis is correct. I think that we try to make the decision about surgical resectability or unresectability, or is surgery a potential down the road up front in the treatment. I think that from a chemotherapy standpoint, if we're going to do neoadjuvant chemotherapy alone, I would lean more towards the CAP combination. I think it has a little bit higher response rate. However, if we're going to do the concurrent chemo radiation definitive approach, I often will use cisplatin and etoposide because it combines a little bit better and safer with the radiation therapy. But I think these are difficult cases, really require coordination across all modalities.
Yeah, we approach it just like Dr. Keston said. We approach it very much like non-small cell lung cancer, and I treat them with weekly paclitaxel, carboplatin, and definitive radiation, like the way Dr. Keston mentioned. And I presume that the full dose radiation is not a problem for you, Dr. Force, when it comes to operation.
No, I mean, it does increase some of the risks and the technical aspects of the surgery, but, I kind of liken it to esophageal cancer, which, we don't, there's not really any difference between a neoadjuvant and a definitive dose, or when we're doing Pancoast tumor. So yeah, we certainly would want the patient to not have kind of suboptimal treatment or split up their radiation, which doesn't really, help them very much. So getting definitive chemoradiation up front would not be a contraindication to surgery.
Yeah. And Dr. Stinchcomb, do you want to comment on, let's say we treat this patient without surgery with chemoradiation, since we talked about this almost like a locally advanced lung cancer, would you then give consolidation durvalumab? And this is an important point, and I just want to bring it up.
So I'll be interested to hear your comments, but I would not at this point. I think one, it hasn't really been validated in the setting. Granted, thymomas are rare, but we know from metastatic thymoma that there's a higher rate of immune-related events. There's concerns about a higher rate of myocarditis. And I think those things are very salient when you think of someone who's been treated with a definitive course who might do well for a period of time at this point, that you first don't want to do any harm.
I completely agree with that. That's why I brought up this question, that there is some concern that these patients are particularly at high risk for, as you correctly pointed out, immune-related neuromuscular toxicities, and especially myocarditis, myopathies, etc. So that does worry me quite a bit. Hopefully, until we learn how to identify these patients, perhaps using some markers, biomarkers testing ahead of time, I don't think we should be giving this in the absence of proven benefit. So I would treat them with chemotherapy and radiation without the consolidation durvalumab. So to summarize our nice discussion here, I would say patients with locally advanced thymic squamous cell carcinoma should be treated with concurrent chemoradiation and then considered for surgery if surgical option is possible, or treated with chemotherapy and radiation. The chemotherapy choice varies quite a bit. I think some of us treat these patients with paclitaxel carboplatin weekly, like any other non-small cell lung cancer. Other options include cisplatin etoposide, as we used to do in the past, with concurrent with radiation treatment. And if a decision is made not to do radiation, give radiation treatment, then the CAP regimen that we have been very familiar with for this thymic cancer is an option with cyclophosphamide, cisplatin, and doxorubicin. It is a challenging disease, and as Dr. Stinchcomb wisely pointed out, it's important to do the path review to ensure that you got the right pathology here. Thank you for that great discussion.